This topic is about cranio-cervical junction abnormalities. These are congenital or acquired abnormalities involving the occipital bone, foramen magnum, or first two cervical vertebrae. These abnormalities can result in neck pain and some spinal cord deficits, cranial nerve deficits, cerebellar deficits, and syringomyelia. Diagnosis is made by MRI or CT scan, and treatment usually involves reduction and, in case of persistent symptoms or progression of symptoms, surgery by decompression of the spinal cord. Usually the abnormalities involve fusion of the atlas and occipital bone, a basilar invagination, atlantoaxial subluxation, clipal field malformation, and a platybasia. Etiology of the cranio-cervical abnormalities are congenital and acquired. Congenital may be systemic or structural. Structural skeletal abnormalities which cause cranio-cervical junction abnormalities are atlas assimilation, atlas hypoplasia, basilar invagination, os odontoidum, platybasia, and congenital clipal field malformation, which is seen in Turner syndrome. Systemic disorders which affect the skeletal growth and development in among the cranio-cervical junction abnormalities are Down syndrome and achondroplasia. Acquired causes are due to injuries which occur due to falls or accidents, and sometimes these may be immediately fatal. Rheumatoid arthritis is another acquired cause of cranio-cervical junction abnormalities, and metastatic tumors that affect the bone are also causing atlantoaxial dislocation or subluxation. Sometimes cranio-cervical junction tumors like meningioma or chordoma, they grow and they cause impingement on the brainstem and spinal cord and cause symptoms. Symptoms and signs of cranio-cervical junction abnormalities are neck pain and sometimes headache. Sometimes in Kyrie malformation, patients may have hydrocephalus, and sometimes sitting upright may cause aggravation of the hydrocephalus and result in headache. Spinal cord compression will also cause some symptoms, which are spastic paraparesis of the arms, legs, or both, impaired joint position and vibration senses, impaired pain and temperature sensation, and tingling of lower limbs with neck flexion, which is also known as lehmaticism. Neck appearance and during the neck movement, sometimes the neck pain increases in cranio-cervical junction abnormalities. In some patients with platybasia, basilar invagination, clipal field malformation, neck appearance will vary. Brain compression causes central sleep apnea, internuclear ophthalmoplegia, nystagmus, dysarthria, dysphagia. Cerebellar deficits will cause incoordination, impairs the coordination. Sometimes vertebrovascular ischemia also occurs, which leads to syncope and drop attacks. Diagnosis is made by MRI or CT scan, and if both are unavailable, or if MRI is unavailable, we can do a CT myelography. Sometimes vascular abnormalities are also found in MRI, and so we can go for vertebral angiography. Treatment involves reduction and immobilization, followed by surgical decompression if the symptoms persist. For most of the patients, reduction means skeletal traction. It is usually done within 8 to 12 weeks. X-rays are done after 8 to 12 weeks to confirm whether immobilization is successful. If it is unsuccessful, anterior decompression is done. Radiation therapy for metastatic bone tumors is usually done. So cranio-cervical junction abnormalities are congenital or acquired. If there is neck pain or any other symptoms of cerebellum or spinal cord or any neurological deficit, we should suspect cranio-cervical junction abnormalities. Diagnosis by MRI or CT scan. MRI is if not available, we can go for a CT myelography. We can do a reduction and immobilization of the neck bones, and after traction and immobilization, if the patient is still having persistent symptoms or any progression of neurological deficits, we can go for a surgery if the reduction is unsuccessful. So immediately after a fall, we should do an X-ray of the neck or a CT scan of the neck or MRI of the neck, and sometimes MRI shows some vascular abnormalities, and these vascular abnormalities should be confirmed by a vertebral angiography or any other invasive method. If MRI is unavailable and CT is unavailable, we should go for a CT myelography. Sometimes patients do not will for vertebral angiography, so we can do an MR angiography. Thank you.